to all those who have joined us for webinar number 137 since the Andean Health Organization, the Hipólito Unanue Agreement, started the webinar series in May 2020. We are celebrating 50 years of the Andean Health Organization of uninterrupted work of joint and coordinated actions with the ministries of health of the 6 Andean countries, Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela, with the vision of advancing in guaranteeing the right to health of the populations. To begin, we will give 3 key messages. First, vaccination against COVID-19 is safe and effective. The more people we immunize, the less likely we are to become infected, as well as protect against severe forms of the disease. Make sure you complete your vaccination schedule. There is no excuse for not vaccinated against COVID-19. Second, climate change threatens life, health, and well-being. Like any crisis, it is an opportunity for improvement. You can or you may contribute to generate social policies and a sustainable development model, join an initiative in defense of the environment, buy local product and plant-based foods, many other actions. And these are an urgent challenge for the continuity of life of the planet. Among other consequences, the socioeconomic and environmental context in Latin America and the Caribbean is shaping a scenario in which hunger, food insecurity, and malnutrition have increased. This is a priority issue that requires political decisions to transform current agri-food systems so that they are sustainable, sufficient, inclusive, efficient, and generate quality that all people can have access to a healthy diet. Reflections on these and other topics of great relevance to health can be found in the bulletin Noti Salud Andinas, in monthly edition available on the webpage of the Andean Health Organization. We invite you to leave your name, organization, and country in the comment box of the Facebook Live or YouTube Live chat. That same space, you can leave your questions or send them via email to webinarhorasconju@gmail.com. In this webinar, we will follow the usual dynamics. We will begin with the institutional greeting, followed by the presentations of our speakers, and then we will move on to the Q&A. To access the certificate of attendance, as usual, in any of the Facebook Live or YouTube Live chats, you will find a fixed link. You must fill out a short survey and then leave your data for the issuance of the certificate, which will be sent in coming days to your email. To begin this important day, I give the floor to Dr. Maria del Carmen Calle, Executive Secretary of the Andean Health Organization, who will give the institutional welcome and greeting. Go ahead, dear Dr. Calle. Thank you, Bertita. Well, the Andean Health Organization, the Hipólito Unanue Agreement, was established by decision of the Ministries of Health of Bolivia, Chile, Colombia, Ecuador, Peru, and Venezuela in December 1971. Last December 18, we celebrated 50 years of uninterrupted work with the vision of making significant progress in the effective exercise of the right to health of the population. Since May 2020, we have been holding webinars every week with the objective of promoting continuous interlearning. I cordially welcome you to webinar number 137, Primary Health Care and Comprehensive Care. The International Conference on Primary Health Care, held in Alma-Ata in 1978, strongly reiterated that health is a fundamental human right and that the achievement of the highest attainable standard of health is an extremely important social objective worldwide, the realization of which requires the intervention of many other social and economic sectors in addition to the health sector. The conference affirms that governments have an obligation to care for the health of their people, a responsibility that can only be fulfilled through the adoption of appropriate health and social measures. One of the main objectives of governments, international organizations, and the world community in the coming decades is to achieve health for all. 25 years later, in 2003, an evaluation was carried out. The central questions were, why didn't primary health care work? Why wasn't it possible to achieve health for all? Some of the conclusions were the following. PHC became part of the official discourse, but there was inadequate understanding of the content. It was not possible to reorient the model of care. It continued to focus on. There were no substantial changes in the training of health professionals. The publication, Renewing Primary Health Care in the Americas, in 2007 from PAHO and WHO, they answered the following question: why renew PHC? And describe the values, principles, and elements for the construction of PHC-based health systems. The core messages were, due to new challenges, knowledge, and context, it is necessary to renew and revitalize PHC so that it can realize its potential to face health challenges. The renewal of PHC implies recognizing and facilitating its important role in the promotion of health equity and human development. The proposed mechanism for PHC renewal is the transformation of health systems so that PHC plays a central role in them. In 2019, the Pan American Health Organization launched a regional pact for primary health care for universal health, PHC 30-30-30, which establishes goals to eliminate barriers to health access and increase financing. Presentation of the pact took place after the launch of the report of the High-Level Commission, Universal Health in the 21st Century, 40 Years of Alma-Ata. In recent years, the COVID-19 pandemic highlighted the need for a renewed and well-functioning primary health care within the framework of universal, resilient, and sustainable health system, adequate financing for health and social protection, with a focus on guaranteeing the right to health, social, and environmental. In this sense, today, we will analyze the main epistemic, technical, political, and financial challenge of primary health care in the current context. Welcome, Cara Hanson, welcome Oscar Feo and Roman Vega. Welcome everyone who joins us. Thank you very much, Dr. Calle. After the greeting of our Executive Secretary, I introduce myself. My name is Bertaluz Pineda Restrepo, Coordinator of Climate Change and Social Inequalities in Health at the Andean Health Organization. And today I am pleased to be in charge of moderating this webinar. Following this preamble, we extend a warm welcome to Dr. Oscar Feo. Oscar Feo is a physician, Venezuelan sanitary teaching researcher at the University of Carabobo in Venezuela, is lecturer at university congresses and seminars throughout Latin America and the Caribbean. He is currently a member of the International Health Working Group of the Latin American Council of Social Sciences. He was founder of the Latin American Association of Social Medicine. He was a consultant of the Pan American Health Organization, executive secretary of the Andean Health Organization, the Polytechnic Agreement, and member of the management team of the South American Institute of Government and Health of UNASUR. Dear Dr. Oscar, thank you very much for accepting your invitation. The space is yours. Thank you, Bertaluz. First of all, I would like to thank and greet the Andean Health Organization, Dr. Calle, who is congratulating this effort they've been doing with these virtual seminars that we can discuss important topics. I'm going to show you a vision of primary healthcare that's quite critical. And I will make a proposal of comprehensive health and life care that, by the way, in my presentation, I do the acknowledgement of the first person that I heard about that is a Peruvian, Dr. David Rivero de Tejada, who wrote an article on why comprehensive care and not primary care. But this is an interesting discussion. And this is the discussion that I'm going to talk in my presentation. Due to the difficulties of internet, we have locally, I sent my pre-recorded presentation, so I asked Bertaluz, so you could please start my video, and I will be here and participating of the Q&A later on, but in order to avoid the internet interruptions that we have in Venezuela, display my recorded presentation. Thank you, Bertaluz. Thank you, Dr. Calle. Please go ahead. Dr. Oscar, thank you so much. Greetings to everyone. I thank the Andean Health Organization, the Polytechnic Agreement, for this space to share with you these thoughts about primary healthcare and to propose the comprehensive care, healthcare and life. In this presentation, I will do basically two things. First, a short summary about primary healthcare, its evolution and limitations, and I'm going to launch the proposal of comprehensive health and life care as a perspective from the critical thought in health to deal and solve the limitations that through history we've seen with PHC. Cara, can you hear me? Okay, great. I will start by showing the fundamental background of primary healthcare before when it was institutionalized in 1978 with the Alma-Ata meeting. Many of that experience is collected in this book from WHO, Health by the People. Kenneth Newell, who was a Pan American Health Organization consultant who compiled the experiences of rural medical assistance in African, Asian, and Latin American countries, and was a very important background for those who organized the Alma-Ata meeting. We have in Eurasia, Russia of a long time ago, the Fellowship in Venezuela since 1962. We had a very interesting experience, which I was part of it, of simplified medicine. In China, in 1965, with the Cultural Revolution, we had the barefoot physicians, and in Central America in the 70s, there was a proposal of primary care in communities that had to do with the Christian groups. All these experiences have a common element, non-physician staff to contribute to the development of care in rural areas, very isolated areas mostly. In addition, there's another important book from John Bryan, Health and the Developing World, written in 1967, who questions the transfer of hospital-centered health systems to developing countries. They call developing countries. For us, express that thought from the North. We think more in a world system built around a core with the North and a periphery in the South, but that's another topic. But this interesting text, because it was translated to Spanish and proposed the need to emphasize prevention of diseases, always thinking diseases. Now, in 1974, a few years before Alma-Ata, a new perspective on the health of Canadians, when Lalonde, Canadian lawyer, was the Minister of Health, and that report was very important for the development of the idea that health had not only to do with health systems, but was a process related with the environment, with health services, biology, genetic, but proposing the need to understand health outside the health services. And then there's this text, and we have Roman Vega, who's the Latin America coordinator for the world coordinator. And this is a text from Maria Hamlin, founding of this movement for the health of people, that was written in 2000, but collects a good portion of the experience that she developed in Central America from those Christian movements or grassroots Christian movements where PHC is something popular at a community level and is a health space for struggle and solidarity. All of this is prior to Alma-Ata. Then we have in 1978 the institutionalization of PHC with the International Conference on Primary Health in Alma-Ata, that at what time it was Pakistan, that was a province of the former USSR. Here we have the two people who organized that meeting, Haldan Mahler, who was the WHO General Director, and a illustrious Peruvian, Dr. David Rivero de Tejada, who was Minister of Health of Peru. But in 1978, he was the Deputy Director of WHO, and he was the person who was in direct charge of the organization of that meeting. Well, that meeting in that Alma-Ata Declaration contains a policy health for all, in a vision based on justice that strives for a new world order and is developed as a strategy to achieve to that health for all, the primary health care. This is important because one of the things that we're going to see later on when we criticize to what happened with PAHO is that they forgot the policy and they prioritized the strategy in a new order of justice, and we emphasize in PHC as a health strategy alone. In the Alma-Ata Declaration was the most advanced for the time. As Mahler mentioned in his words, is a response to the biomedical hegemony focused on the disease and is the most advanced because for the first time it promoted health as a right, universality, the comprehensiveness, social participation, and intersectoriality. At that time, I was a recently graduated physician, and we learned about that statement. We got in love with it. I'm part of the generation of PHC. I graduated in the 70s and we lived through that process. But what happened with PHC? Well, a few months later, after the Alma Ata meeting, UNICEF and the Rockefeller Foundation organized a meeting in a large center that the Rockefeller Foundation has in Bellagio, in the Lake Como in Italy. And in that meeting, they hijacked the PHC. They removed this characteristic of being comprehensive and converted into selective PHC. And this is clearly written. I recommend to read this information. Mahler itself criticizes this in the role of UNICEF and the Rockefeller Foundation, that process of converting PHC in selective care. Well, what they did, PHC was reduced to a limited number of high impact low cost benefits for the poor, good health at low cost. And that's the text that was called the GOVI program. And GOVI is the acronym for G for growth control, O for oral rehydration, B for breastfeeding, and I for immunization. And PHC was reduced to 4 treatments where when the Mahler and WHO and Tejada vision was a comprehensive PHC. And then following the criticism, they added micronutrients, literacy for women, only for women, and family planning. I was part of this process. In 2003, I was a consultant in the areas health policy and system in Pajo and Washington, and I was very close to working with a commission, Dr. Mirta Rosas, who had the Pajo organized to evaluate 25 years of Alma Ata. And by the way, in that commission, I was working closely with David Tejada, who was part of it, and I was moved by his insights because in that evaluation, 25 years after Alma Ata, they were asking what happened to PHC, why it was not possible to obtain health for all. What have we learned? What should be the lines of actions to achieve this? And most of these insights are published in this PAHO journal in 2003, What Happened with Health for All. And there's a formidable article of David Tejada where for the first time he speaks about comprehensive healthcare. And David proposes, both in addition to explaining what the idea of Alma Ata, and this is a very interesting slide of 2004 from a presentation, Dr. Rosas, the head of the Pajo, using a phrase from David Tejada, which is David Tejada mentioned at that time. He said that comprehensive health care for all and by all is the best way to express Alma Ata's genuine primary health care. It's a necessity not only in the field of health, but for the future of countries that aspire to remain sovereign nation states in an increasingly unjust world. Well, there's a very interesting publication from Dr. David Tejada that's called Comprehensive Healthcare. This is the first time that I heard about this term was from him, and then I could share in Peru in several opportunities. And he insisted the original sin of the Alma Ata was the inadequate translation because primary healthcare care in English was translated as attention. they changed care for attention. In English, it's primary health care, but it was translated as atención primaria, primary attention. And the second mistake was the confusion surrounding the term primary, because primary in the Spanish dictionary means first in order or grade, or also means primitive, elementary, or uncivilized. So UNICEF and the Rockefeller Foundation followed this second definition and turned it into a primary care that was called primitive health care for the poor. Well, after 2003, 2018, 40 years after Alma-Ata, not 25. And what happened? Well, WHO organized a meeting in Kazakhstan. There's no more Soviet Union. This is the Republic of Kazakhstan in Astana, and they organized a conference where they invite all the ministries of health and people involved in primary healthcare. That was called a Global Conference on Primary Healthcare. And the title, very interesting, is From Alma-Ata Towards Universal Health Coverage. That was the motto of the meeting. So what happened? Well, the Alma-Ata Declaration became an appendix of Universal Health Coverage. PHC, in that declaration, committed that would be the instrument to achieve universal health coverage. So from Alma-Ata of 1978, of a PHC for Health for All, we moved to the primary health care from Astana for universal health coverage that has had many criticisms in terms of being placed at the service of universal coverage that has demonstrated a functional proposal to the market of health. In that opportunity, in 2018, I was in Bolivia, and I was doing a consultancy for the PAHO, and one of the things they asked me was to write the lessons learned in those 40 years, and these are the things that I mentioned in that meeting. First of all, more importance was given to the strategy than to policy. PHC was put ahead to Health for All. Number two, there was an inadequate understanding of the PHC concept. There was confusion with the first level of care. In Europe, when you talk about PHC, it's to talk about the first level of care or the gateway to a disease-focused system, and that has also occurred here. The Horace Conru did a study a few years ago about PHC, and he was telling me, I have to assimilate PHC as first level care because there's no other way to work now. Number three, big capital take over PHC and turn it into selective PHC, what it was called to primitive care directed to the poorest of the poorest and as a package of services. The model of care has not been reoriented. It continues to focus on disease. The training needs of the new type of professional were not taken into account. Physicians, nurses, and health professionals continue to be focused on the hospitals, centered on disease and curing. And finally, the most sad of all, PHC became part of the official discourse. Today, PHC is part of all the reform proposal of the World Bank, of the World Health Organization, and the movement for the health of peoples. So there's a major confusion because everyone uses it their own way. This is for me a central focus. PHC has become, in those 40-something years from Alma-Ata, in one of the main themes of the health discourse from the north to the south, I say that PAHO has become a myth. PhD has become a myth. The myth is defined as a wonderful narrative set outside of historical fact. That's PhD. A wonderful narrative that when we can implement it is going to solve a health problem. And the second is a person or thing surrounded by great admiration and esteem, and qualities or excellence are attributed and that it does not have. So 40 years from PhD, all the evaluations that have been done tells us that PhD has lost its transformative power and has reduced to a minimum of benefits for the poor, a minimum of benefits and, and, and a gateway to medical systems or a component of the basic packages of neoliberal reforms. That is why from the comprehensive health and life care, we are doing a proposal. And the proposal is, instead of attention, we talk about care. Instead of primary, we use comprehensive. Comprehensive care of what? Of health and life. It implies a vertical and asymmetrical relationship between one or two who offers when we talk about attention. The one who attends knows, and the one who is attended does not. Instead, care implies a horizontal and symmetrical relationship where everyone knows and has responsibilities and duties. The comprehensive health and life care that we are proposing and the critical thought in health combines intersectionally conceptual approaches, action strategies in the different areas of social life and moments in the course of life. The fundamental approach is that of social determination of health, not isolated determinant. The law, the feminism approach of the intercultural approach and the social class approach as an important significant element in working on the health systems with comprehensive strategies where we privilege the promotion of health and life, but we also add prevention of diseases, healing, and rehabilitation when they are needed in all the spaces. First, in the social territory, which is where we build life. We need to make that the health system goes from the hospital or the outpatient as the center of the system and start as with the assumption that the center of the system is the territory where life is built and where we express effective ways of life. Job space, production space, family space for reproduction and consumption, and the individual space where we have the clinical aspects. And then we'll talk about the life course that goes from birth to death. Well, this is our proposal. Comprehensive care displaces an institutional, bureaucratic, geography of care, which is vertical and population control, to a social geography where health systems are built as a web of territoriality, territories, and dynamics of social reproduction, where the expansion of that new institutional framework places the territory where life develops and health is produced at the center. Well, this is my intervention. Thank you so much to all of you, to the Andean Health Organization. My greetings to the other speakers and the comprehensive healthcare and life to be based on public policies coordinated to the whole of life and no longer thinking in development and well-being that the North has built for us, but in our own perspective of living well and good living that will allow the satisfaction of the needs of everyone. Thank you very much to everyone. Good afternoon. Thank you, dear Dr. Oscar. Excellent presentation. will talk us about the background of primary healthcare, the importance of the Alma Ata Declaration to face the biomedical model, but also the difficulties for its implementation. Among them, for example, the reduction of the concept of THC. That is why he indicates the need to go beyond the concept to a comprehensive health and life care for everyone. In his presentation reminds me some central ideas of the book Refoundation of Health Systems in Latin America and the Caribbean, Decolonizing Theories and Policies, which also there is a chapter written by you. I would like to tell those of you who are joining us that these webinars are recorded. You can hear them again. You can listen to the presentation again, where we emphasize the need to generate comprehensive care. In this book of Refoundation of Health System, they emphasize the need to generate other epistemology for a transformative political action from the global south and a critical theory of health system. And this book tells us that we need to rethink or open new questions, new doubts, and theoretical approaches. An essential step for this, if this regional health sovereignty. Thank you very much. Please continue in the room. We have many comments, many positive comments and several questions. After the presentation, we will have a Q&A to respond all of these. Now we would like to welcome and thank you so much for accepting to participate as a speaker to Dr. Kara Hanson. Dr. Kara is professor of Health System Economics and Dean of the School of Public Health and Policy at the London School of Hygiene and Tropical Medicine. She received her PhD from the Harvard School of Public Health. Over the past 30 years, he has researched the economics in health systems in low and middle income countries and the role of the private sector in health systems. He has also conducted work on the opportunities and constraints of the private sector to improve the efficiency, quality, and responsiveness of health systems. He has worked in Africa and Asia and on health financing reforms. He is president of the International Health Economic Association. She chaired the recent Lancet Global Health Commission on Primary Healthcare Financing. Welcome, dear Dr. Kara. You have the floor. Go ahead.
Thank you very much, Bertha, and thank you very much, other guests. It's an enormous pleasure to be able to speak to this audience today. I'm going to share my screen, and then I'm going to ask somebody to tell me if it's the right thing. So can you see the slides in presenter view? Excellent. Okay. So as Bertha said, I chaired the recent Lancet Global Health Commission on financing primary health care that was produced, that was published in April this past year. And I'm really looking forward to sharing some of the key findings with you. Let me first tell you a little bit about the commission. So we were really starting by recognizing the fundamental importance of primary health care, that it is this platform through which essential health services are provided. It provides the opportunities for preventing and treating chronic conditions at the lowest level of the health system. As we've learned over the last 2 years, more than 2 years, it plays a frontline role in responding to epidemics, both through disease surveillance, but also through the management of mild illness and through the delivery of vaccination programs. And it really is a prerequisite for achieving the Sustainable Development Goals and universal health coverage. But that funding for primary health care is often insufficient, and it's often channeled inefficiently as well. So that's what we call the financing arrangements. And that can lead to systems that are inefficient and poorly performing, that fail to provide financial protection to households who continue to need to spend substantial amounts of money out of pocket. And it also leads to inequalities in access to care. And I guess the third background point here is that COVID-19 has created a profound health and fiscal crisis, but it has also shown us how important primary health care is. It's shown us that those countries that had strong primary health care systems were able to protect their citizens better, and that societies face dangers if they don't have a well-functioning primary healthcare system that protects everyone. So our commission was made up of 22 commissioners who were drawn from different parts of the world and drawn from the experience of national governments, of technical agencies, of bilateral and multilateral donors, from academic institutions, and from policy research institutes and think tanks. It was supported for the 18 months of its deliberations by a team from the London School of Hygiene and Tropical Medicine, and I was privileged to be the chair of the commission. Our objectives were to present new evidence on the levels and patterns of global expenditure on primary health care, to analyze the key technical and political economy challenges facing financing primary health care, to look for areas of proven or promising practice that would support primary health care across the health financing functions, and finally to identify some actionable policies to support low and middle income countries in raising, allocating, and channeling resources to support effective, efficient, equitable, and people-centered primary health care. So I'm going to start by giving you an overview of the current situation of financing primary health care. But before I do that, I just wanted to pick up a few issues, of definition. And some of these definitional issues, of course, speak to the presentation that Oscar just made about what do we mean by primary health care. Pardon me. So the first is a question of sector and perspective. So as Oscar outlined, the original vision of primary health care was very much one that is multi-sectoral. It involves numerous sectors in contributing to health and well-being. From our perspective, what we were interested in is the financing of those services. And so we identified as the key actor that we wanted to influence was the Ministry of Health, trying to get ministries of health to recognize the importance of spending on PHC and also getting them to allocate more funding for primary health care. So while we certainly embrace and accept the very broad definition of PHC, for the purposes of financing, we were seeking to influence health budgets. The second definitional issue is how you define expenditure on PHC. And the system of health accounts uses two different approaches for classifying expenditure. One is the healthcare functions, and the other is healthcare providers. The Organization for Economic Cooperation and Development, the OECD, cross-classifies those. So it sets a health system platform and the PHC functions that are delivered at that platform level. And the Commission were in agreement that that is probably the most appropriate way for the purposes of expenditure tracking and measurement to define PHC, that services are delivered through platforms. As Oscar said, PHC is not a set of interventions. It is the platform that meets healthcare needs. However, having said that would be our preferred definition, the World Health Organization's expenditure database only reports primary healthcare expenditure according to healthcare functions. So we had to use those figures, but we would conclude that those figures probably overestimate primary healthcare expenditure, because it does capture some PHC that's delivered in higher level hospitals. And we would argue that that's really not at the essence of PHC. Finally, also speaking to Oscar's point about comprehensiveness, I think he's quite right that often in Europe, we talk about primary care as if it's primary health care. Actually, primary care is mostly individual focused. And we would embrace a definition of PHC that includes not only primary care, but also the essential public health functions that are delivered at the PHC platform level, and also care that is delivered through community health platforms. So having accepted that comprehensive PHC definition, I will admit that our report is much quieter on the subject of how do you finance those essential public health functions, part of primary health care, and also the community health platform. And that's because we were a commission that was driven to look at evidence. And actually in the healthcare financing literature, there is much less to say about financing those essential public health functions, other than identifying them as being critical. And likewise, surprisingly little information about how community health platforms are financed. Why are definitions important? Because we want to measure things consistently, at least consistency within a given country over time. And that's because that also provides an opening for accountability for spending decisions, and also accountability for commitments to increase spending. So what do we know about spending? We were particularly focused on measuring government spending because we believe that public funding for PHC is essential if it's going to drive out high levels of out-of-pocket payments. And you can see here from these figures that we've disaggregated by the income level of countries, that government spending on PHC is really, really low. So in low-income countries, it amounts to about $3 per capita, and only $16 per capita in lower middle income countries. We were quite determined not to come up with any new estimate of what the ideal spend is. There's plenty of those estimates around, but I can assure you that these very low levels of spending are very far indeed from the minimum spending levels needed. What we also found is that out-of-pocket expenditure is the main source of spending on primary health care in low-income countries. So you can see actually that in low-income countries, out-of-pocket spending is 4 times more the level of government spending. And we would argue that this is a situation that really needs to change, that individual spending out of pocket at the time that care is sought is a really unfair, unjust way of financing a health system, and that there really is a need to shift from a predominant reliance on out-of-pocket spending to one that relies more on government spending. I'll just add that most of that out-of-pocket spending is on medicines. Another piece of our analysis showed that households are actually more exposed to out-of-pocket payments for primary health care than they are for non-primary healthcare, so for everything else. So if you just look, these are for different income groups. I'll draw your eye to the bar in the middle, which is the mean level of spending out of pocket on PHC in our blue bars, and then everything else and in the orange bars. And at every income level, countries are spending a greater share of PHC services from out-of-pocket payments than they are funding other services. So we're really doing a very poor job at protecting households from out-of-pocket payments. Why does spending matter? Well, spending matters, first of all, because it's highly correlated with coverage. So this just does a plot of the level of government spending on PHC per capita against the UHC service coverage index, which is a reasonable index of services that make up primary healthcare. It includes some non-primary healthcare, but it's easily and readily available because it's one of the SDG monitoring indicators. So clearly, the more you spend, the higher coverage you get. This is an upward sloping curve. But also for any given level of spending, particularly in low and lower middle income countries, there's an enormous variation in the level of coverage achieved. So our big take-away message from our commission really almost derives from this slide, which is that governments really need to spend more, but they need to spend better, because clearly countries are getting very different levels of performance of their primary healthcare systems at the same level of spending. And that variability always points to areas for improvement in how money is spent. And finally, just to flag another area we looked at, we were very interested in how pooled funds are transferred to public primary healthcare funders. So what economists would call the provider payment mechanism. And just to warn you of one of our conclusions is that capitation is the best way for paying for primary healthcare. But you can see actually how rare capitation is as a way of paying providers, extremely rare in low-income countries. But even in lower middle-income countries, less than half providers have some form of capitation. Less than half of countries have some form of capitation in their payment mix. So our findings and our deliberations really were organized around the health financing functions. So that is how money for health is mobilized and pooled, how it is allocated to PHC and how PHC is favored compared to other uses of money, and then how PHC providers are paid. But importantly, we felt that from the very beginning, we need to recognize that these financing decisions are underpinned by political economy considerations. And so we set to characterize the political economy context in terms of its economic and political and social elements. And that the role of political economy really infused all of our discussions. I'm going to talk very briefly about each of these financing functions and let you know what our main kind of analysis found in terms of the best arrangements for financing PHC. So the first is around mobilizing and pooling. So we felt that that sufficient public resources is essential to support PHC and to limit the need for harmful user fees. And that it is possible to spend more on health from public funds, but it does require deliberate action to increase tax revenue by improving the collection of existing taxes, by increasing the tax base, and by expanding the number and types of taxes used. We also recognize that increasing tax revenue is a technical issue and a political issue. And that's very much part of the sort of the compact between citizens and their governments. Their willingness to pay taxes is very importantly determined by issues of politics and of trust. We talked a little bit about efficiency savings as a way of generating fiscal space for PHC, but we felt that the potential to generate efficiency savings, at least in the short to medium term, is very limited. And finally, we argue that pooling arrangements, that's the sort of the arrangements that bring money together to protect populations and to enable cross subsidies that embody solidarity across those who are ill and well, and those who are rich and poor. Those pooling arrangements must start with PHC. So while I'm intrigued by Oscar's notion of comprehensive healthcare, we would argue that when fiscal space is constrained and you have to start somewhere, you should start with PHC, because that is the platform at which such a large share of health problems can be addressed. I'm going to skip over that slide and move now to resource allocation. So So if we start from this position that governments simply don't spend enough on PHC, it's so far short of the minimum needed to finance a package of primary healthcare services, then we need to think about how to allocate money. And the process of securing budgets for PHC is not just a technical budget issue. It's not just how you move money through the budget, but it's also influenced by political forces. And those political forces very often favor urban areas, and they very often favor hospital level care. So there is a political imperative to persuade decision makers of the importance of primary health care. A lot of our discussions in this section of the report addressed issues of the policy levers for formulating and executing budgets, but also, maybe a little bit surprising to us, the importance of service delivery arrangements as ways of channeling money to PHC. We spent a lot of time thinking about the difference between centralized systems where ministries of health get budgets and allocate those, and decentralized systems where, just to caricature these, you might have a block grant that goes to local government, and then local governments decide how much to spend on health versus other types of public services. So we're all in agreement that this question of whether to be decentralized or not is a political question. In decentralized systems, it is more challenging to increase allocations to PHC because those allocations are less visible, and that more types of policy tools might be needed in decentralized systems to increase spending on PHC and to track those expenditures. In all systems, multiple tools are needed, and often they rely to function well on having a clear operational definition of PHC. And finally, we were not advocating for a new Department of Primary Health Care in national ministries, but we did feel that it was really important that it's clear where responsibility lies in order to both increase accountability for expenditure on PHC and to increase the political support for it. So in our discussions, we identified three main categories of policy tools. One is around how budgets are formulated and can be used to ring fence and secure commitments for primary healthcare expenditure. The second was around the execution of budgets. And here we were looking at things like resource allocation formula, but also importantly, the purchasing arrangements for primary healthcare. So thinking about what is the set of services that is being secured with budgets, how are providers paid, and through what sorts of contracting arrangements. And I use the term contracting in a very loose way to mean, what are the agreements that underpin these transfers of funding. And finally, I think interesting, because it does link to this issue of what do we mean by PHC, that service delivery arrangements themselves can be an important way to pull resources to the primary healthcare level. So a number of countries have increased their spending on PHC by changing their service delivery model. So by, for example, in Ethiopia, introducing a new cadre of health extension workers that has the effect of dragging resources out to the periphery, or by setting clear norms and standards, or by structuring the referral system and gatekeeping, trying to keep patients and keep resources at the primary healthcare level. Our third health financing function that we looked at for securing and protecting resources for PHC was around provider payment. And in most countries, PHC providers are paid through sometimes input-based budgets, sometimes through fee-for-service payments. And here I'm talking about government budgets. So I mean that budgets are transferred on the basis of the number of services provided. In some places, they're paid for by capitation, and in other places by performance-based payment. And we argued that capitation, some form of population-based payment mechanism, creates the strongest incentives for PHC providers to deliver people-centered PHC. And that's because capitation starts with the principle of equity. It provides an equal payment per person. It then, so it's kind of a horizontal equity notion, that can then be adjusted to create vertical equity based on health needs. That it pays providers not just to provide services, but to manage population health, to prioritize health promotion and prevention. And also, importantly, that it provides a predictable and stable revenue basis for PHC providers that allows them to plan well. However, all provider payment mechanisms have disadvantages as well as advantages, and capitation also has disadvantages. So we actually argued that countries should initially move towards a capitation-based system, but then to expand that by using other types of primary healthcare payment mechanisms as well. So a blend that strategically mixes, for example, capitation with pay for performance, or capitation with block payments for providers in rural areas. And we sketched out through our discussions a pathway through which countries might think about moving from the status quo, where there's a budget or a fee-for-service based mechanism, through to a simple capitation mechanism, and then as systems become more sophisticated, to mechanisms that are based on adjustments to those capitation, and then eventually to blending. And that trajectory enables, you can see on the vertical axis, a change from a system that is poorly aligned with people-centered PHC to one that is very well aligned, and also that changes the purchasing orientation from one that is passive to one that is more strategic. So our fourth part of our commission looked at the political economy of financing PHC. And by political economy, we meant politics and economic conditions and social conditions. And that these political economy elements were as important as having clever technical designs. If you're looking at it, designing and implementing efficient and equitable finance from PHC, that this needs to be accompanied by a political strategy as well. And this is because those political economy factors create both constraints and opportunities. So managing those requires understanding and navigating that evolving political economy context. We found that at all income levels and in any type of political governance model, it is possible to prioritize PHC if there are effective political alliances and socioeconomic conditions. And in looking at sort of case studies of countries that had really made progress towards prioritizing PHC, that many of them were able to articulate a very clear long-term vision. That developing PHC financing policy and ensuring this investment requires alignment of political actors through collaboration and coalition building. And that sequencing is important. So there's a matter of kind of watching for political opportunities, but being ready with technical fundamentals and strategies ready so that you could move when there is a window of opportunity that arises because of a particular political dynamic. So just to conclude then, I'll just summarize really where our recommendations landed. So we deliberately chose this phraseology. We wanted to speak about people-centered financing because we believe that people-centered financing is the pathway towards people-centered PHC. And what we mean by people-centered financing is it has these attributes. It means that PHC is predominantly publicly funded through tax revenue that's collected through progressive means. That pooling arrangements that cover people should cover PHC first. That resources should be allocated equitably across levels of service delivery, and that those resources need to be protected from the forces that tend to drag it back up the system so that it really does reach frontline PHC providers and patients. And that a people-centered financing approach should use a blended provider payment that has capitation, which has these people-centered characteristics that I described, at its core. Our second recommendation was about the importance of taking a whole of government approach. And by whole of government, we really meant both up and down government, so the central ministries of health, but also important roles for local government, but also that there are horizontal elements as well. So there are roles for the Ministry of Health, there are roles for the Ministry of Finance, making sure that enough revenue is collected and mobilized to fund primary health care, that the Ministry of Finance accounting systems can be flexible and responsive enough to make these allocations to primary health care visible, protect them, and allow for strategic payment systems. That local government plays this important role as a bridge between populations and the central government. And that there are roles for other actors also, important roles for communities and for civil society in demanding change and holding providers accountable. For providers themselves, who are also people at the center of this system, that they and their representative organizations need to be involved in the design of provider payment approaches, and that they need to be incentivized to provide people-centered care. And then important roles for technical agencies and donors to do no harm, to work to reduce fragmentation, and to serve as strategic partners. Our other two recommendations, one was about the politics, so making sure that, that technical strategies are underpinned by an understanding of the social, economic, and political conditions. So this means mapping the landscape, using stakeholder analysis tools to understand interests, and then to actively align them and build coalitions, to work towards strategic collaboration and compromise, and all the while making sure that the basic health system functions are continuously improved and strengthened. And finally, we had a recommendation for the global agencies that should re-examine how PHC expenditure data are collected and classified and reported. So I would just like to conclude by drawing your attention to some of the Commission resources that are available in Spanish. So on the Lancet website here at the bottom, the executive summary has been translated into Spanish, Portuguese, French, and Chinese, and it's available on the Lancet website. And we've also developed a set of policy briefs, an overarching brief, and then 4 specialized ones that have also all been translated into Spanish. I'd like to acknowledge my outstanding set of commissioners who worked tirelessly for 18 months, completely during the pandemic. Our first meeting was scheduled to start in April 2020. And so we had to run the entire commission online with monthly meetings and many discussions in between. And I'm very grateful to all of them for all the work they put into producing this work. And then to also acknowledge the Gates Foundation for the grant to support this work and the partnership of Lancet Global Health in its publication. Thank you very much.
Thank you, dear Dr. Cara, for your excellent presentation. You showed us a report of the Lancet Commission on financing of primary health care. And well, you have told us that the COVID-19 pandemic highlighted the need for well-functioning primary health care. However, public funding for primary health care is insufficient. Therefore, the need to get the financial agreements right is a very important way, needed way to support the development of people-centered PHC. In your presentation, you emphasize the importance of the concepts and the need to develop mechanisms to improve the financing that's centered in people and the responsibility of the different levels of the government and the population. Thank you for all the ideas that you have shared. Please stay in the room. We have very positive comments about your presentation and also several questions that we will deal later. Thank you very much again. Now, we would like to welcome Dr. Roman Vega, surgeon, graduated at the Universidad Nacional. It's a master in health and social security administration from Javeriana University, PhD in administration in the public health and interdisciplinary doctorate in social and human sciences. He is recognized as emeritus and life researcher by the Ministry of Science, Technology, and Innovation of Colombia. He is a former Secretary of Health of Bogota, former leader of the Trade Union Medical Association, ASMEDAS, and TOC Sindicales, and the former National Federation of Health Workers. He is a researcher, scientist, and professor at the Universidad Javeriana, and he's currently the global coordinator of the People's Health Movement. Thank you very much for accepting the invitation. Go ahead, Dr. Vega, you have the floor. Thank you, Berta Luz, for inviting us to share this webinar with my colleagues. I would like to thank Dr. Cara and Oscar for the elements that you have provided for discussion. Extremely important, as well as Maria del Carmen, who introduced the story of primary healthcare. I believe those elements are key for the reflection that I would like to propose around this topic, that we've been working in the field of research, but also with government exercise.
En el año 2004,
2004, in Bogota, we worked on a proposal of recovering primary health care under a district government against a history of exclusion of primary care and the health reform of the country. It was a very politically dramatic moment in terms of the official debate and the public debate generated through the idea of recovering primary health care in Colombia, where we were accused of reviving a dinosaur that had been buried by the health sectorial reform, whose emphasis, and we need to remind that, was the financial management of the system. And of course, it generated a major crisis in terms of public health in Colombia, of which we are still not over yet, due to the structural limitations of the universal coverage model, which is the core emphasis of the Colombian health system that the current government wants to change. What I would like to propose today as a central element in the debate that has been opened around PHC. First of all, I believe that there's a global consensus on the effectiveness of PHC. This is not just an agreement of the governments and the multilateral agencies or from stakeholders in the health business, but also with the communities, and in that these People's Health Movement have collected for more than 22 years an important experience. But to have a global consensus on the effectiveness of PHC doesn't mean that we agree on what to understand by primary health care. And the reason for that primary health care as a health systems are policies and strategies that are crossed over by political and ideological differences around the interpretation of the scientific evidence. So we've had different historical traditions and dispute about the conception of one in the other systems in PHC approaches. I would like to remember this chart that tells us there's no single discourse or single conception of the health system. There's been many historical models that go across these differences that I mentioned, and the emphasis has been different from those who conceive health as a personal matter, in general, as a disease, in addition to those who see it consumption good or as an insured and guaranteed services. Perhaps the idea of universal coverage is follows this conception, or the conception of the national health services like the UK. That example has been very important for the history of health services, up to the experience of other economic models with other different conceptions of the health systems. Up to date, historically, the Cuban health system, which is a state-run and socialized system. So we have different models of health systems that are in dispute. And today the dispute is much more evident, but we also have different models, different approaches of primary. I'm not going to repeat them. I just would like to mention two that were trends. The one that looks for an interpretation as something comprehensive, and to those that have been historically built in the selective approach that Oscar mentioned, that today has become, and this is the result of research that we've done in Colombia, as a neo-selective approach. And I will mention why this is a neo-selective approach, the one that's being proposed very strongly from Astana. One should study the reality of PHC considering some area. What are the characteristics of health policy in each? Secondly, what are the attributes of it that those policies allow? And of course, this has to do with the forces that regulate the reach or the scope of policies and practice of primary healthcare. The second thing that I believe is important is to which the global north from the global south. The conceptions of global north are mainly clinical and biomedical or PHC. But the global south, social, economic, and cultural reality is quite different than those of the global north, propose of a more comprehensive and intercultural approaches. More than intercultural approach, as I'm going to say later. And those differences indicate that we need to focus PHC, that PHC should be focused on people, beyond individuals, in human populations, and of course, on health services, which is the current hegemonic idea, but with the idea of having comprehensive care, as Oscar mentioned, of life and health. Two approaches because they demand spaces for developing primary healthcare that are different, and that's very important. Now, the current dispute of the interpretation has been polarized, and we really state that those who work more in the idea of creating the relationship of PHC proposals with the national health service and socialized health systems versus those who promote or propose privatized health systems or with public insurance of socialization of financing of health systems under this proposal of universal health coverage that in most countries has a strong emphasis oriented towards the market, therefore to open spaces to the private offering of primary health care services. That's a dominant strategy. That's the discourse of the World Bank, of WHO, and many agencies and private stakeholders who finance research in this area. But it is important that we characterize a number of elements in the characteristics of health systems, both in terms of services and those services related to primary healthcare with other sectors of the society. And in that, it is clear how much primary care is as a result of planning in terms of the allocation of resources for health care, not only for medical services, how much the financing mode and allocation of resources, both in services and sectors who do not depend on these services, has met health needs. How much the proportion of public financing of PHC with respect to the total health expenditure. What about the proportion of spending is done with respect to primary healthcare systems compared with specialized hospital services? What type of PHC personnel, and not only physicians, the strategy that the country has? What percentage of that active PHC personnel, physicians, nurses, of community health agents whose efficacy in primary healthcare has been proven in many regions of the world and from other health resources? What is the ratio of income among PHC personnel in the case of physicians, general practitioners compared to specialists? What is the way of PHC personnel is paid, in particular physicians, compared to the specialists? What is the usual location, the health sector of those PHC services? Is the dynamic of assignment of do we have the assignment of patients to a health team? Do we have 24/7 access to care? What about that coordination between physicians and especially physicians in the care of patients, including those patients who are hospitalized? What is the centrality of primary care, primary health care in the process of patients' care and management in the care system? And what is the plans in a development plan of countries, territories? How is that primary health care in our Latin America, in particular, that we have ancestral populations that are important determinants in our countries? How are we including the pluri and interculturality in health and guarantee the territorial autonomies in the actions and decisions related to health? What about the strength and degree to which the departments, I am talking about the academic institutions responsible for the training of the PHC personnel, are adapted to the characteristics of PHC? These are crucial elements without which we couldn't speak about the core issues of primary health care. Of course, the key attributes are also important. Among those attributes, I would highlight the comprehensiveness of care. How is that comprehensiveness achieved? In addition to other important elements, among them, the orientation, the community orientation, the family approach, the characteristics related to the intersectorial action to address the needs beyond health services. What about this individual and collective participation in action planning? How, in terms of plurality and interculturality, the institutions and the communities themselves practice this plurality of health, knowledge, and practices with regards to PHC. These are crucial elements, key elements. The Commission of Health Determinants established by WHO in 2004. We were the group who analyzed health systems. And if we think that the health systems are systems that are equitable, we need to understand that the comprehensive primary healthcare is core in the building themselves. Now the debate is focused in terms of comprehensiveness, selectivity or neo-selectivity of the design and the practice of primary healthcare. And I would like to remind you that the issue is not only of the degree of universality and amplitude of benefits or biomedical interventions of primary healthcare provided to different groups of population, or the degree to which these benefits are provided directly by the teams in PHC. Comprehensiveness has to do with the correspondence between health needs and the PHC response through comprehensive actions. As I mentioned, the treatment and prevention of diseases, health promotion, and rehabilitation, but by prioritizing responses according to the analysis of the specific reality of each case, family, each territory. That's the issue. This is not a rigid proposal. This is a flexible, open proposal with the realities that one faces. I would like to show an example. One of the persons that impressed me has already dead, Dr. Sanders from Western Cape University, South Africa, West Cape University, with the comprehensive approach. You have diarrhea, as I did as a physician in Bogota medical centers. You need to offer them a response in terms of vaccine, prevention, and tell mothers to feed their children so they can get cured. That's what the central emphasis in primary healthcare. But in our countries, as opposed to the global north countries, we have unresolved issues in our society. One of them was, to give you an example, the absence of drinking water, the absence of basic sanitation in our communities, especially those that are socially excluded at the urban level and rural level. And it's the lack of food sovereignty and security. How can we deal a problem from the primary healthcare approach, such as diarrhea, without doing first an emphasis in what's determining a diarrhea, not only mitigating diarrhea? A primary healthcare approach, of course, has to consider the whole picture, but it needs to have central emphasis, which is determinant for the conception of PHC. And this is what Alma Ata proposes in 1978. I would like to point this out because I believe Alma Ata is not buried. Alma Ata is alive and primary healthcare is alive. Any other proposal, for example, that the one that Oscar about comprehensive care is welcome because it's aligned with primary healthcare, as Oscar mentioned, in the voice of someone so important such as Dr. Cara. I think the primary healthcare has not to do with that. That's not the issue. The issue is that there is a dispute, and that this is a dispute that is facing any other approach to be proposed, because this is a political issue, it's an ideological issue, and the results of science are not absolute. This is the core problem that we have. But primary health care highlights things that we need to understand. It's not an issue of services, it's also intersectorial action and community participation. And the biomedical approaches exclude in their emphasis these core elements which are indispensable for any comprehensive approach that wants to be proposed in terms of health. That is the issue. And I think it's worth to remember the evolution of this conception since the initial program of primary healthcare quite flexible with 8 major elements that affected the World Bank in order to face the inequalities between the global north and the global south in terms of health. We need to do large investments because, as Dr. Cara, the core issue is how many resources do we have to what we do, what we intend to do to solve the people's needs. And that was the PhD program for a long time. 8 major elements in the that was changed under a dispute that was not technical, but it was political instead in terms of economic developing models for this selective model, which is the source of the neo-selective approach that universal health coverage is considered for many respects for those who work with this idea of universal health coverage. So it's against, this is what we're facing, and this exercise of differentiating the comprehensive approach from the selective approach is not new. It was done in the London School of Hygiene and Tropical Medicine in the 80s, where they proposed this dispute, and there was a number of important elements that I'm not going to detail about the differences between that approach and that of primary healthcare. Beautiful papers about that debate that is worth that we consider. So, what I would like to mention basically is the tradition of selective PHC, of the GOBI problems, first 4 and then 8 in cost-effective interventions, cost-efficient interventions, focus on the prevalent diseases of the poorest of the poor. That tradition has been maintained by the industrial medical complex accumulating capital, the multilateral agencies, and multiple other stakeholders through an approach that I have called a neo-selective approach that plays with this proposal of universal health coverage. The Lancet did a study in 2018 and indicated in that year a number of interventions in 218. There's a mistake. It's not 2008. It's 208 sectoral health interventions that should be delivered. What in Colombia we call it a plan of benefits for the Social Security General Plan of Health. 218 of which 198 are of primary care that should be moved, like Dr. Para mentioned, to the primary healthcare platforms with the proposal of universal health coverage. And we need to clearly state why is this is the approach that is where the financing is based on those conceptions established by these studies that were retaken by the ASTA Declaration. So I think that this is the issue. Therefore, in the global experience, this design based on benefit packages selected with cost effectiveness and cost efficiency criteria focus only on the individual is supported by the neo-selective PHC model. And that's the problem. That is the difficulty that this model designed in the global north has for the countries of the global south with different realities. The financing arrangements of PHC based on selected benefit packages and on the purchase of services through public funds are functional to the commodification and privatization of PHC and to, of course, requires that integration as a neo-selective approach. This is an issue. I'm not going to stop there. Dr. Cara has done an excellent presentation of those results from the Lancet Commission that has worked with this approach. But the issue here is that this design has an unnecessary separation between individual intervention and public health. The Social Security General System of my country, a model of this universal coverage health. It prevents PHC from being linked to the economic and social development of communities and territories because the emphasis of finances is placed in the packet of interventions that have been selected with the criteria already mentioned. And of course, it prevents PHC from promoting a central worldview and cosmovisions and practices in health, prevents that to develop the territorial autonomies and the pluri and intercultural autonomies in health. And this is a core issue that has to do with the realities of our countries. We may conclude, therefore, just a generic proposal. Now that we are in campaign for the transformation of health system in many countries in Latin America, among them Colombia, that the limited approach of neo-selective PHC is effective in facilitating the governance of marketized and privatized health systems, but not in caring for life and health in general. This is the comprehensive approach being pluricultural and intercultural remains a necessity in our countries and should focus on biodiversity and healthcare from the territories. This is what we are asking for with the participation in the political debate and the social debate. Thank you so much, Berta Luz. Thank you for your presentation, dear Dr. Roman Vega. You have emphasized the importance of Alma Ata. I like the idea that it's still alive and PHC recognizing that a comprehensive approach with this neo-selective characteristic. You tell us that it's important to acknowledge the need for those political debates and to have a political position. You also emphasize the need to ask ourselves important questions for why and for what the health systems. The great capacity of innovation and transformation in the redesign of the relationship between society and state is where the starting point for rethinking health systems. That is why we were showing us several slides with core questions about the characteristics of health systems that favor and orientation towards primary health care with the key attributes of practicing PHC. And you also emphasized the need of this approach of PHC that's comprehensive, pluri, and intercultural as a need for our countries in the South and center on diversity and care of people and territories. Thank you very much to the speakers, to Dr. Oscar Feo, Dr. Roman Vega, and of course, Dr. Cara Hanson for your excellent presentations. We received many comments and questions from people that have connected. We thank for all of those from the Ministry of Health and the University Social Organization from Bolivia, Chile, Colombia, Ecuador, Peru, Venezuela, Argentina, Cuba, Guatemala, Honduras, Mexico, Panama, Paraguay, Dominican Republic, the US, among many other countries. We have received many greetings. Thank you very much. Now we're going to move to an important part, which is the Q&A. And this is going to be carried out in response to the questions and concerns. I would like to take the opportunity to read the questions that we have systematized and pulled. For Dr. Oscar Feo, what will be the reasons by which, despite having important background of comprehensive care of health, we still do not achieve the adequate positioning in our health systems? What are the barriers and the priority actions? And also a question for Dr. Oscar Feo, the role of South-South cooperation in the PHC and life, and what is the role of each one has people who are listening and participating in this webinar to position care, the comprehensive care of life and health. For Dr. Cara, they ask, what are your specific recommendations with regards to the influence of the economic level and the market in terms of health, promoting health, and to improve financing? Also, in relation to the following questions: how to overcome structural problems that we have in our Andean countries. For example, the material adversity when there's a predominance of a conception that we don't have the institutional capacity. With this state, we cannot work. It is very difficult to get financing. This is not the time. You have to wait. I don't know if you I spoke too fast about the questions, Dr. Cara. Of course she did. And then for Dr. Cara, wants to know if could you comment on the importance of the political community in terms of health and social justice. And for Dr. Roman, could you please reflect from your experience as a health secretary of Bogota and the lessons that you've learned about the role that the health personnel has in the developing of multisectorial process to approach and to deal with the social determinants of health? And if you could please also comment a significant experience that includes the comprehensive model and the intercultural approach. Those are the questions that we have systematized. So now, please start in the order that you made your presentation. So Dr. Feo, you start. Thank you, Berta Luz. It has been so interesting to listen to Cara and Roman's presentations, and I will focus in commenting your two questions. Why so much resistance? Why so difficult? Well, this is so very funny for me. Roman states the fundamental characteristic of primary care has to be comprehensive. Well, but we still call it primary. It is difficult for us to change the name from primary to comprehensive. We are all aware that the word attention takes us to the traditional activity. Why? By that evidence that the care is better than attention and comprehensive is better than primary, from the point of view of terms, why is so difficult? The difficulty has to do with tradition, the identification with faith. We've been talking for PhD for 50 years, and we still resist to change that wording, but the issue is not the wording or the discourse. Today, the World Bank, the Bill and Melinda Gates Foundation, the Rockefeller Foundation, WHO, PAHO, but also the Movement for the People's Health, ALAME, speak about primary health attention or care. And each one wants to say things that are completely different. Well, myself, I think that more than continuing doing efforts to differentiate from PHC from the World Bank, I rather to decide more on the concept that has more epistemic clarity, but there's also a problem of substance. And the problem of substance is that we in the South, in particular in Latin America, we have built during 100 years our health systems based on theories and policies from the global north. The health programs, I'm not going to talk about PhD, that the only way to relate between the Ministry of Health and the population were brought to the continent by the Rockefeller, the fight against schistosomiasis and malaria, and they continue to be today programs that are centered and vertical in nature, but we continue to insist that health programs are the core of the activity of the ministries. And I could mention so many other examples. The health systems have been built with the North epistemic, with a policy and a theory and a practice from the North. And I believe that one of the requirements for a deep transformation in health is to build public health and health systems with the proposals and epistemologies from the South, and no more being trapped with the discourse and epistemology of the North. Of course, I respect anyone that wants to continue talking about PHC, and you want to do it adequately at the comprehensiveness, that's okay. The problem is not how we call it, it's how I do it. And the how I do it is also linked to the theories and practice of the global North. So to break what we call to have a colonial posture that builds sovereignty and allows us to emancipate from the North implies a major challenge that has political and methodological expressions that imply a debate about the discourse. And that is part of the issue in which we're working, but there's also some resistance because if I have 50 years working, this was born with the chart of creation of PSC, and it is difficult to get away from that, and I understand it. There's a lot of commitments, a lot of identification and faith also. So some we see it as it is part of something that I believe and I need to continue believing. Otherwise, I am a rebel. That's not important. Second topic, the role of South-South cooperation. This is extremely important. And when I talk about South-South collaboration, I'm talking that we're used to a collaboration that comes from the North, it comes to South. And this is, and today it's been demonstrated that more than 60% of cooperation that comes from the north to the south is in consultants, work for consultants of the north and purchase of equipment from the north. We need a different model of collaboration. And that new model has also the need to break the coloniality that we have of those cooperation models that come from the north. What I believe that the core issue is that we can be able to break with that model, that model that makes us reproduce the theories and methodologies and the practices from the global north. Many times when we are part of the government, we have reproduced those models that come from the north. Well, I'm in a current that proposes the idea of health sovereignty, that proposes the need to emancipate and the need of independence, and that has to do with breaking with that epistemology of the north and to build our own south ecologies under the frame of an ecology of knowledge. That's all. Thank you, Dr. Oscar. Go ahead, Dr. Tara.
Okay, thank you. So I'm going to take two questions. The first was about what is the influence of the market and the economic level to increase financing for primary health care. And I think there it's really important to distinguish between the size of the cake that's available for all government spending and then what share of that gets allocated to health. So that pie that is government revenue, it is, if we think about the common sources of fiscal space, it's either taxes, it's growth, macroeconomic growth can increase the tax revenue, and it's taking debt, or it's external assistance. There aren't really many other ways of increasing that pie. But I do think that in the discussions about health financing, there's often been a certain pessimism about the ability to generate revenue from taxes. And I know many years ago, we studied countries that had made a significant increase in their tax revenue. And it was through deliberate technical and political actions. And so I think it is within the capabilities of governments to collect more tax. And you can look at statistics on what is the size of tax to GDP to look at countries that are in some sense underperforming in terms of tax revenue. But it is possible through the creation of greater tax collection capacity and also greater trust and commitment of there's a commitment of politicians and trust in politicians to collect more tax. And that gives the opportunity to spend more. The next trick then is how much does the government wish to allocate to health? And that, of course, is a political discussion between the Ministry of Finance and the Ministry of Health. And then the next step is within health, how much priority can be given to PHC. So I think that countries at all levels of development and all levels of economic performance have the potential to increase their spending on health. It's a matter of commitment to do so. The second question was about how do we overcome the structural characteristics and institutional capacities? And I think that's a really good question, a really excellent question. I think there's probably two elements to my answer to that. One is it's true that spending well on primary healthcare requires capacities across the system, but also that it's possible to start with very simple things. So allocating health budgets on a per capita basis is not a technically difficult thing to do. It's something that can be done and has been done by countries at very many levels of development. And then as capacities increase, it's possible to increase the sophistication of those systems for resource allocation. But it is possible to start simple. And then I suppose to go back a little bit to what Roman was saying, to think about how do you use that money to fund a real PHC platform. So not to fund interventions, and I hope it wasn't misunderstood, because I wasn't talking about funding interventions. I think that PHC is a platform. And then the question is, how do you want to design that service delivery platform, and how do you want to, and then how must it be financed to be able to deliver that comprehensive set of actions, whether that is, public health functions, whether that is services that are and advice and support that's delivered by community health workers. So the funding of that platform is what is essential. So thank you for the questions.
Muchas gracias, querida doctora Cara. Por favor, doctor Román.
Gracias, Berta Luz. Las dos preguntas son muy importantes porque están relacionadas con vivencias y realidades de trabajo en la atención primaria muy concreta. En Bogotá tuvimos la osadía de revivir la atención primaria en medio del modelo de mercado, que es de seguridad social en salud actual. El gobierno quiso ir un poco más allá. El planteamiento de ver la atención primaria en salud como un problema simplemente del sector salud. Y comenzamos a discutir entre los secretarios del gobierno de ese periodo cómo generar una innovación institucional que nos permitiera un diseño integral y un financiamiento integral de las necesidades de las poblaciones que han estado separadas en la acción del gobierno. Alimentación por un lado, cuidado de los viejos por otro, de los niños por otro, de las adolescentes por otro, y cuidado de los servicios de la enfermedad y de la prevención de enfermedades por otro. Queríamos generar una integración de las acciones institucionales desde el nivel distrital de los recursos para responder a esas necesidades. Y se creó algo que se llamó, en función de ello, la Secretaría de Integración Social, como una entidad aparte de la Secretaría de Salud. El diseño quedó a mitad de camino, porque la salud fue excluida de la idea de la Secretaría de Integración Social, que a la larga derivó en una Secretaría de Asistencia de Pobres, en la política de seguridad social asistencialista. Derivó en eso, pero esa fue una de las lecciones centrales. Y las otras dos lecciones que quisiera tener en cuenta.
Can you hear me now, Cara? Sorry, I didn't push the right button.
Sorry, I'm hearing you. Fueron las intervenciones
Were the
relacionadas
interventions related
con el recurso humano en salud. Y
the
allí
human
tuvimos
resource?
dos problemas. El primer
And there
problema,
we found two issues.
la política de flexibilización
First,
de las relaciones laborales
Flexibilization policy
ha impedido que los
has
trabajadoras de salud tengan
health
condiciones
workers
de empleo y de
have
trabajo
adequate conditions, work,
estables y adecuada remuneración. Se ha
and
producido
adequate
una
pay,
precarización del
salaries.
trabajo y, por supuesto, una
And of
alta
course,
rotación de personal de salud.
a high
Y
rotation
eso
of health
atenta
staff
contra
and that
los
went
productos de la
against
atención. Por ejemplo,
the
la
conditions of
relación
healthcare.
permanente
For example,
de
the
cuidado entre las
permanent
instituciones
relation
y
between
las
care
personas,
and
familias.
the institutions and families,
Pero también tiene un
but
impacto
also
enormemente negativo.
has a
calidad.
negative impact
De
in
modo que esos son
quality.
elementos centrales. Y el otro elemento clave
The other key element
es la formación del personal.
is training of the health.
Después de 10 años de haber sido
After 10
despedida,
years
encontramos
in
un personal de salud
consider we found a health person
sin idea de lo que era
that has
trabajar
no
en el marco
idea
de una
of what is
concepción de
to
atención.
work in
Un personal
the framework of primary healthcare.
de enfermedades para asistir un pequeño paquete de
Were
intervenciones
difficult to
desde el modelo del
start
sistema
a little set of intervention with this
no
general
era
model.
adecuado para
Sorry,
poner
his
un
audio is breaking up. Cara,
familia
difficult to follow.
I'm sorry, I think I have a noise here. I'm hearing you. Maybe I have to organize the
A ver, tengo que organizarme acá.
Entonces, un personal no
So,
formado para
An untrained personnel for PhD is a waste of resources and a waste of time in terms of the objective of primary healthcare. We need to create a revolution. And I want to say in that terms, in the training of the resources, and implies a transformation of the curricular contents of the university that have to do with health, so people learn how to work and do actions and plans and to work with the communities and not only applied interventions under small programs of intervention as is being done in Colombia that are isolated from the reality of the communities. That is a major transformation, not only of health institutions, but also of the education institutions. The other element that I think is key the question about the significant experience for comprehensiveness and interculturality. I recently visited Guatemala with the Association of Community Health Services in Chimaltenango. This is an organization by the Mayan indigenous communities from this country. We were discussing what is that about the new normality after COVID-19. And in that analysis, we were collectively more than 200 representatives from these communities, midwives, traditional healers, authorities, Mayan spiritual guides. What was the experience of those communities in the 19 pandemic? And there are two elements that say a lot of what could be a primary care approach. I think that we can agree on the terms, Oscar. The important thing is what we want to say. And in that experience, the Mayan communities had to rescue a large portion of their ancestral practices and knowledges that were lost in the process of Western culturalization of the Mayan communities in order to respond to the isolation needs under these conditions generated by the pandemic. But they not only did that, rescue their own knowledge, but they also were core elements so that actions trigger from the Western health service, for example, vaccines, the use of the face mask could be culturally accepted by the communities with this intercultural dialogue. These are realities, and we can replicate and reproduce them according to the cultural traditions of each people. People are quite diverse in our region. In my own country, Colombia, I have to say that as a result of decades of war, farmers and indigenous communities have had to build their own cultures in terms of healthcare and nutrition and food production with a situation of isolation of more than 6 decades in territories due to war. This we have been discovering following the research with the farmers communities. And they also claim for their own practices, for example, the knowledge of medicinal plants that are effective for the management of many health problems. They have been considered and have included and have been recognized and have been valued from their own practice. Thank you very much, Berta. Thank you for the wonderful answers. We thank all of you for the questions. We will not have time to respond all of them, but we will consider them to define the following seminars. We thank you for your participation. to close this space of Q&A, I will ask the speakers to leave us a final message. Just 1 minute, your final message. Dr. Oscar, you go first. Thank you. In 1 minute. Okay. I rescue from Alma Ata the idea of health for all. But I also rescue the idea that we cannot, after 45 years of Alma Ata, continue to fail as those Millennium Development failed, or where 70% of the country didn't comply, like the SDGs are going to fail. Why? Because today, in the world we live, health is placed in the market. And there are interests of the large capital. This pandemic impoverished 90% of the population, but it made 10% wealthier. Among them, the big financial, industrial, medical companies of the pharmaceutical industry. While health is dominated by the capital interest, we will continue failing having health for all. So I finish my meeting by saying we continue to fight for a real health for all, but that implies a positioning from the South against the interests of the capital and goes against privatizations and marketing of life and services. Bye. Thank you. Dr. Cara, go ahead.
Thank you, Bertha. So I would conclude by saying that I think everyone on this panel was really committed to a vision of people-centered primary healthcare, and that to achieve that, we need to make sure that our arrangements for financing that, so for getting money there and getting enough money there, also need to be people-centered, and that governments really need to be persuaded to spend more and to spend better on primary healthcare. Thank you.
Gracias.
Thank you.
Adelante, doctor.
Go ahead, Dr. Vega. We are in Latin America in a new political context and in a new opportunity for transformation of the health systems in primary healthcare. Oscar, attention, be careful. We can talk about that in depth. And this is an opportunity for society. Come to the debate and place this in public agenda, the changes that they need to do under this frame of primary healthcare. I think that what Chile is Honduras, Colombia, as new experience, even Mexico, and perhaps Brazil with a new government of Lula that I'm sure is going to win the elections. What they're telling us, there is a new opportunity to learn from the mistakes that we have collected adequately, Oscar, in the study of the South American Institute of Government, in the work we did about PHC in all the countries of Latin America. Those lessons need to be learned. We cannot repeat those failed attempts. The light is here for us, and along the way, we need to follow it. Thank you. We would like to thank for the excellent presentations of today, Dr. Oscar Feo, Dr. Cara Hanson, Dr. Roman Vega, to all of you participants, to the team from the Andean Health Organization, and to all the people who participate in this activity, which has been possible thanks to the commitment with the Andean and Latin American integration. I give the floor to Dr. Maria Carmen Calle to close this webinar on behalf of the Andean Health Organization Hipólito Unanue Agrumen. Go ahead, Dr. Calle. Thank you, Bertita. Well, my first words to thank Oscar, Roman, and Cara. It has been a very interesting webinar because we have heard very interesting positions. As an old public health expert, I remember that in the 1980, I was working in a first level of care in Lima, in one of the poorest areas of Lima. And Olga Amati Leon came very enthusiastic, which is a recognized public health specialist, and she came with everything that had to do with primary health care. And it was amazing. Why? Because we did family records of those 30,000 dwellers. We learned of what were their conditions. We look for more affordable medicines. We work with the local councils, and we try to put the best possible health in reach of everyone. That, my dear colleague, was in the 1980. Then when I started, I was very impressed because I went to visit a hospital and there was an office that said primary health care. So I said, how we have understood this? This is not right or well understood. Well, in time, I became an advisor to the General Office of Health Promotion, and one of the most important topics that we were administering was the topic of determinants. We can discuss that later, Oscar, but we spoke about determinants, and we did a lot of force to that. When I was a vice minister, I was lucky, so lucky, that David Tejada de Rivero, that for us is an icon, is one of the public health specialists most important from Peru, gave last presentation before dying. And the topic, what was it? It was primary health care. And he said comprehensive health care. This is what Don David said, indicated that care is horizontal, attention is vertical, care is horizontal. That we need to achieve the healthcare for all, not only physicians, and for everyone, with no distinction. And that it was the most inclusive approach because PHC is a strategy, although many countries consider as a first level of care. And the truth is that we are tired of that discussion, so each country has its own definition. But he considered that PHC was the most inclusive, equitable, cost-efficient, and effective approach to improve the mental and physical health of people, well as social well-being. These are words from Don David. Well, let's remember what primary health care is. This is a strategy that includes everyone. The society as a whole has to do with health. It's not only the health sector. It also talks about rights. We have the right to enjoy the highest level possible of health, and that we need to remember, as Roman mentioned, this issue of interculturality. And we in our institution have it very clear. Last year in the COP, when they asked what innovation things you have for climate change, among our lines of work, we put the dialect of knowledge. We understand that the original peoples have fabulous strategies to deal with climate change. So we do believe in this. We believe in prevention. We believe in promotion. We are fully convinced that the issue is not to focus on the disease, but to focus on health. But we cannot leave aside the fact that we need to have a strong, an inclusive system, a resilient system that has adequate comprehensive networks. And when you have the first contact with health, you can have major opportunities that they can solve the problem at that moment. And this is what we don't have in our countries. We need to be honest. We're still lacking those things in our country. I think that we could continue talking about this, but what I do believe that it is true is that we need to continue working strongly. So health is in the center. What we've seen with the pandemic of COVID-19, I'm 42, I've been working for this doctor for 42 years, and I've never seen health in the center, in the core. This is the first time. This is the first time that the Ministry of Health spoke with the Ministries of Economy and Finance. The first time. But what are we seeing in these recent months? That we are no longer, health is no longer important. The important is the economic recovery. And I don't know, they no longer thinking that the importance of health for economic recovery. I think it's been it's a fascinating webinar. Thank you so much for your presence. And what we need to say is that primary healthcare requires that the government in all their levels underscore the importance of taking measures beyond that health sector, because we know that we don't have water, we don't have housing, education, social protection. What health for all are we talking about? Thank you very much. Once again, thank you, Berta. I also thank all the Andean Health Organization that made this webinar possible, number 137. We invite you for next Thursday. Next Thursday, we're going to get an update of this monkeypox. See you September 8th. Good day, good afternoon. We have more than 700 people joining this webinar. Thank you very much.